With this, we invite Dr. Bhagirath to speak on heart failure with preserved ejection fraction, the essentials of diagnosis.
The most important element is once your patient comes to you with breathlessness, you have to do a detailed clinical examination. At the end of the clinical examination, you should have some working diagnosis, whether it's a cardiac disease or it's a pulmonary disease, and then only order the relevant investigation rather than ordering a battery of investigation and thinking that the investigation is going to fetch you the diagnosis. It's only going to create more confusion to the patient.
Good afternoon, everybody. I have a very interesting topic to speak on, that is heart failure with preserved ejection fraction. I thank Professor Nagaraj Desai for giving me this opportunity to speak in this forum. I'll go by the guidelines, so I'll rush through the slides. In case anyone needs more clarification, I can always stop by. So basically, heart failure with preserved ejection fraction comprises nearly 50% of the population of heart failure patients. Significant mortality and morbidity. The only catch is that it's a heterogeneous disorder. You have multiple comorbidities and multiple variables, all culminating as heart failure with preserved ejection fraction. Clinical trials have used the definition of heart failure with preserved ejection fraction as LVEF more than 50% with accompanying evidence of structural heart disease or elevated natriuretic peptide levels. So this is the diagnostic algorithm as per the guidelines. So may I draw your attention here, wherein the heart failure with preserved ejection fraction is LVEF more than 50%. Now this is the algorithm that I am following for the diagnosis of heart failure with preserved ejection fraction. It is PE, F1 and F2. So the P is the initial workup, symptoms and signs, comorbidities, ECG, the natriuretic peptides, the ergometry or the 6-minute walk test, and the CPET or the cardiopulmonary exercise test. Next up will be the diagnostic workup, advanced workup, and then etiological workup. So let's quickly rush through all these parameters. So the first segment is looking at the ECG and then the standard echo, natriuretic peptides, and then the 6-minute walk test and CPET, which is the P segment or the initial workup. So obviously the signs and symptoms, I think Srikanth has already dwelt on this. The symptoms basically fatigue, weakness and so on. Signs are the elevated JVP, third heart sound or a gallop, displaced apical impulse, bilateral basal crepitations and pleural effusions. It's usually seen in an obese elderly lady with hypertension. Why is it so difficult to diagnose and to treat heart failure with preserved ejection fraction? Because I already told you that there are multiple disorders which can manifest as heart failure with preserved ejection fraction. As we go through the layers, you will find that there is a different problem in every patient. But ultimately, when you see the echo, it's all one and the same. So let's unravel this mystery and find out. Let's get deeper. Apart from that, you have multiple comorbidities also. You may have lung disease, you may have iron deficiency, you may have renal dysfunction, but yet the echo parameters or the echo features are almost as similar in all the patients. Now this is about the ECG in heart failure with preserved ejection fraction. You have evidence of left ventricular hypertrophy. The PFEV1 is, there are studies that have been done on this, the PR interval, the PQ interval, the QT prolongation and so on. So let me give you a snapshot of what are all the possibilities that can go wrong in an ECG. Wow, this many papers, each of them have publications saying that this is the parameter that is deranged in heart failure with preserved ejection fraction. I've just picked up a few, that is the index T end to P by the PQ into the age of the patient. This is supposed to be very sensitive and specific for heart failure with preserved ejection fraction. There is high PQ and QTC intervals, PQ time, P wave dispersion, biphasic P waves, which indicates the biatrial enlargement in such patients, and of course an index which measures the LVH amplitude signals, and the P wave amplitude also is supposed to be very sensitive and specific for heart failure with preserved ejection fraction. Next up is the biomarkers. You can see that there are this many biomarkers. Many of them are available as a strip test, which is commercially available. It just takes 10 to 15 minutes to run one drop of blood and you get all these parameters. But let me tell you that already Srikanth has emphasized on this, that the basic diagnosis for heart failure with preserved ejection fraction is looking at the NT, pro-BNP and the BNP. You have separate cutoff values for atrial fibrillation as furnished here. 6-minute walk test It's commercially very viable. You just need a certain space in your hospital. Sometimes you can even use a corridor and you can accomplish this. The good thing is it is easily reproducible. You can measure the patient's improvement. Sensitivity is about 70%, specificity is close to 80%, and a 6-minute walk test of less than 300 carries a poor survival index. So be wary of such patients and keep them on more intense monitoring and follow-up. Cardiopulmonary exercise testing already has been discussed in great detail. We look at the VO2 max, we look at the carbon dioxide production, the production, ventilation of, and the slope of carbon dioxide production per minute of ventilation. Most importantly, specifically the VO2 max is associated with survival. So this is a very, very important parameter. You must have this value, and this will help you to extrapolate how good your patient is in terms of physical fitness. Next up is the comprehensive echo and the natriuretic peptides. This is the E segment of the diagnosis. So this is a snapshot of the echo, the various, that is the parasternal long axis, short axis, and so on. So let me get you into more detail in the echo, because this is something that's readily available for us. The important thing here is, if you see the normal diastolic function and the abnormal diastolic function, I think the pointer doesn't work. So the segment on the left, you can see that the ascent is much faster, which means that the filling pressures are raised in this patient. Of course, the panel here shows you the sequence at which the cardiac cycle is progressing. This is an animation of the mitral inflow velocities. You can see what happens to the E and A in grade 0, 1, 2, and 3. This is the mitral annular velocities. Again, what happens in grade 0, 1, 2, and 3. So these are beautiful animations to illustrate the inflow velocities. And again, the important thing is pulmonary venous velocities. You can see here what happens in grades 0, 1, 2, and 3. So this is what we eventually do in the patient. This is one of our patients who was evaluated in greater detail, and this is the classification, how far down the line your patient is, based on these three parameters here, that is the mitral Doppler velocity, pulmonary vein velocity, and Doppler tissue imaging. You can see that your patient can be in normal, grade 1, which is abnormal relaxation, grade 2 is pseudo-normal, grade 3 is reversible. You still can make a difference to the patient, and grade 4 is when the patient is out of hand and has progressed beyond redemption. These are the guideline cutoff values. I'll just leave you with this slide so that you can assess these on a day-to-day basis in your patient. There's another parameter, that is the increased LV filling pressures, and there is a late score. You can see the score here, the left atrial reservoir strain, the TR velocity, and the EA average. And you have a 0, 1, and more than 2. More than 2 indicates that your patient is too far down the line and needs more aggressive therapy, and the outcome is likely to be a 6 on 10 for that particular patient. These are the other things that we look at: tissue Doppler, the LA volume, an important parameter, and of course the PA systolic pressure. This is summarized aptly in this one slide, which shows mitral inflow, mitral annulus velocity, LA volume, and tricuspid flow. The LV mass index, you have major criteria and minor criteria. Mass index is again for, there are separate cutoff values for males and females, as well as minor criteria. The other thing is the LV global longitudinal strain. The GLS less than 16% is a minor criteria to say that this patient has heart failure with preserved ejection fraction. This is one of our case studies wherein the longitudinal strain was 12%. So again, this indicates that this patient had heart failure with preserved ejection fraction. So one snapshot to summarize the entire echo parameters. Accordingly, you can give points to the patient, and based on this, you can come to your assessment whether this patient has heart failure with preserved ejection fraction. And this is again to summate the functional morphological biomarker in sinus or in atrial fibrillation, and the points here. If the patient has more than 5.6 heart failure with preserved, and if it's 2 to 4, diastolic stress test or invasive hemodynamics, that is the next level of testing, is often required for this patient. Let's move to the next segment, advanced workup, diastolic stress echo. These are the ways in which you can do a stress test for the patient. Either you do a proper treadmill, or you can do a bicycle ergometer, or drug, that is dobutamine or vasopressors. Let me draw your attention to what's important here: average E by A prime more than 15, or the TR velocity more than 3.4. So E by A prime more than 15 carries 2 points, TR velocity of more than 3.4 carries 3 points. So if you have the criteria filled, your patient has heart failure with preserved ejection fraction. If it doesn't, go to the next stage, that is invasive hemodynamic monitoring. Here again, you have at rest and during exercise. So how do you exercise a patient? You make the patient lie down and ask him to do the bicycle while the cath is in progress. So if your LV EDP is more than 16 or the wedge is more than 15 at rest, then you have heart failure with preserved ejection fraction. If you don't find that, you exercise your patient, and if your wedge moves to more than 25, then that means that this patient has heart failure with preserved ejection fraction, as you can see here. Next up is the other more advanced ways in which you can investigate the patient, including cardiac MRI, cardiac biopsies, scintigraphy or CPET, genetic, and of course specific laboratory tests including a biopsy. So I'll quickly run through that. You can get an etiological workup based on the cardiac MRI. So in one slide, if I have to tell you what is the utility of heart failure with preserved ejection fraction, here it is. Precision of measurement in terms of LV mass, LV volumes, RV volumes, and so on. Diastolic evaluation, we've dwelt on it already. Ischemic heart disease, there or not there, hypertrophic cardiomyopathy, constrictive pericarditis, and so on, coming to a specific diagnosis, and of course, some idea about the underlying pathology, tissue characterization, is it sarcoid, is it amyloid, what else can you find out? For all of these, the one-stop shop is cardiac MRI. This is the grading, how the diastolic function by cardiac MRI is done. This is a snapshot. I'm not getting into the details. And this is something called as atrial kick, which you can see on an echo as well as on a cardiac MRI. If you see the way in which it is normal versus diminished versus absent. So that the panel 1 is heart failure with preserved ejection fraction in a stage of reversibility, and the last panel shows that it cannot be reversed. Your patient is out of hand. Similarly, if you see the diastolic septal bounce, it is a rapid change in LV volume in late ventricular diastole. So again, the progression, mild versus advanced. Clearly, you can see the difference on a cardiac MRI. These are certain case reports. This helps in both segmental and sectoral. You may have only one portion of the ventricle which is affected. And this is again, we do the T1, T2 and color coding images. And this is a case of sarcoidosis that you can see here, which we followed up with a biopsy. This was a gynecologist. And this patient, after diagnosis, we put her on both steroids as well as cyclophosphamide, completely normal now, without any symptoms or signs. This is again the still images of the same patient, another patient of amyloidosis, not diagnosed hitherto. And then this is again the MRI of that patient, followed it up. The important thing that you can pick up here is what we call a zebra sign. You can see that this is white, black, white. So this is called as the zebra sign, which is pathognomonic of amyloidosis. Of course, this is the T1 and T2 images at various intensities, which further aids in our diagnosis. Another thing that we've just added, another toy that we've just added is a myocardial tagging for the diastolic function in cardiac amyloidosis. We break it into small segments or grids, as you can see that, and based on this, you have a cumulative score which can tell you where exactly your patient stands or how far down the line your patient is. Why? Because amyloidosis now has treatment, but even if you treat, you won't get a complete recovery if your grid score is too far down the line. This is the most amazing thing that we've added in our hospital. This is the normal 4D, what we call as the 4D MRI. This measures the flow inside the left ventricle. If you see here, this is a normal flow. This is how it looks on a color-coded image. And then last is the heart failure with preserved ejection fraction. If you see the difference clearly between this segment and that segment, you know what exactly I'm talking on. The entire cardiac cycle is slowed down in a patient with heart failure with preserved ejection fraction. Another thing that we can do with a 4D flow MRI is the measurement of the LV flow vortices, that is the A vortex and the E vortex. Suffice to say that these parameters are grossly deranged in a patient with heart failure with ejection fraction, with preserved ejection fraction. So if that is slowed down, you've got your man, you've got your patient, you need to up the ante and treat him more aggressively, or you can even, based on these parameters, tell your patient and family that he's too far down the line, best you can do palliation. That's it. Last is the PT or the PET CT that we did for sarcoidosis. This again is the lady gynecologist. This is the PET scan that we did for PET CT for this patient, and you can see that there are numerous sarcoid hotspots or deposits. This we can even, if you do a sectoral analysis, You can pick up exactly where in the heart this hotspot is, target your biopsy accordingly. I could pick up that, and this is the next panel showing that we picked up a granuloma in this patient. Hotly debated whether it was tuberculosis or sarcoid. We found out that it's sarcoid because we did the other parameters which were negative for tuberculosis, treated the patient on steroid, not so optimal response with steroid. We increased the aggressiveness of treatment by starting cyclophosphamide once in 2 weeks. Patient is totally okay now. A repeat biopsy, repeat MRI was totally normal in this particular patient. This is my last slide. We have a scoring system. After this big discussion, we have a scoring system which is the HFA, that is H2FpEF score, and the HFpf score. So these have got, these are the parameters that you look into, and this is the same thing in a different way, and I'll highlight what's important here. Low probability score of 0 to 1. If the HFpf score is 0 to 1, this is low probability for this patient. Intermediate probability is a score of 2 to 5 in the H2FpEF score, and HFpf score of 2 to 4 indicates intermediate, and of course high probability is if the score is 6 to 9 in the H2Fpef score, or HFpef score if it is 5 to 6. So with this I conclude. Thank you very much.